That's it from me. Over to you.
Thank you, Dr. Sibul, for those insights and for sharing those statistics and findings of our report. Now, to better understand what AI, ML, and the entire gamut of the new technologies available to us to prevent, detect, and even look at surveillance can do for the health of our nation. I'd like to now call upon Dr. Sujoy, the Chief Medical Informatics Officer, to give us his insights on this subject.
Thank you, Karan. Good afternoon, everyone. So you just heard from Dr. Sibul and previously from Dr. Sangeeta that how we have been collecting this data in different formats across our different hospitals and multiple encounters that we have from with our patients, whether they are coming to our outpatient clinic or health check or camps, or even when they are utilizing our virtual consults, or they are coming and getting admitted to our hospitals. For all of those data, we have been now been able to build clinical AI models, which are looking at a set of clinical predictors through a very robust selection process, where we are determining it with multiple factors that we gathered through either through our health check or through our outpatient clinics or through the discharge summaries. What is mainly interesting here is this, that there are risk scores that are being prepared all over the world, and it's been going on for the past 20-25 years with data that are there for 70 years and all. But in many of them, you do not have a way to put your feedback. If somebody is using that tool, is the data from that individual goes and makes that particular tool more robust. This is what we are doing. We are learning with that and able to enhance our tools over a period of time. The other thing is we saw quite a lot of different medical calculators which are which have been tested over a period of time. Their accuracy on even population has been always a bit wavering. Particularly on the Framingham, we saw that in our own study, we could have a maximum of around 0.5 to 0.6 AUC or 50 to 60% accuracy. The other thing is how do we go about using this data in a prospective way and take that data to validate and make the models more robust. Going into that, the outcome that we are getting now of the models that we build for our cardiac, which we call as AI-CVD, where we are looking at a person's risk of developing cardiovascular disease in 10 years, or if the person would have pre-diabetes, diabetes if he has not checked, or acute exacerbation of COPD, or liver fibrosis in people with diabetes or non-alcoholic fatty disease. One of the most important things is that these are built on risk factors which are more applicable to Indian population. Second, it brings in the concept of deep learning, where we are able to use, across the data set, the interplay between different factors, which gives us a much more deeper insight than simple calculation or arithmetic calculation that happens in the United States. The other thing that we have been able to do is to take these risk scores outside of Bolo within India at different medical college, prestigious medical colleges, and also outside India at Maastricht University in Netherlands. Now we are looking at other hospitals across the world, including Southeast Asia, Middle East, and others, and have been able to validate with their population what we are trying to build here. And finally, that is all that we are looking from a population health perspective, but on a personalized perspective, we are able to utilize what Ma'am was talking about, clinical decision support, which would help the doctors to actually put the patients into some sort of modifiable strategy which will reduce their risk over a period of time. Another important thing that from the development from the last 1 year is this, that all of these clinical APIs have now been certified as medical devices Some of them are being published, so we can always talk about that. So in continuing with what we just saw in Dr. Anupam's slide, where we were looking at people from different walks of life having a certain percentage of NCDs. When we looked at a group of people who were coming to our health check and looked at their cardiac risk score, we got some very interesting numbers that almost 1 in 2 of these people who are coming in preventive health who has one concomitant or comorbidities are actually having higher risk scores. So high risk is anywhere between 14 to 20, 21%, and the moderate risk, which is normally missed out without this particular tools or the AI-enabled tools that we have, is something that we are finding it somewhere between another 15 to 20, 25%. And that is the area that we have been looking in as an intervention. And many times we are asked these questions that once we have got these high risk stratification or moderate risk stratification, what we do. And this is one of the path-breaking study that we have been doing at Apollo, where we are not only validating our models, AI models with structured lab tests, but we are also looking at them to see how we can follow individuals with higher risk groups and to see how their risks are being modified over a period of time. Now from the NCDs, I would now go on to the effect of NCDs on COVID. And this is a published study in Nature last year where we compared diabetes, hypertension, heart diseases, kidney diseases, and others in the wave 1 that we had from April to October 2020 to the surge that we had last year from April to May 2021. And what we found out that the comorbidities like diabetes, hypertension had an odds ratio of almost 3 times in individuals who are having diabetes or hypertension would have it from people who do not have that. This is about the mortality. We found that the heart, for the hypertension, it was about close to around 2.4. Kidney diseases, it was about 4.7. So that brings to a very important conversation that for people who have been discharged from our hospitals in the past 18 months, how do they have been followed up? And we are taking a small cohort here, about 30% of people who had followed up after the first wave, and the data of the 18 months are available. We could see 3 distinct trends. One, that there are people who are suffering from long COVID, and they are returning to our pulmonologists and are talking and seeking their advice, particularly around the lung complications. The second is for people from 6 months onward, 6 months to 1 year in particular, they have been coming back to cardiologists and not coming back, they're coming to the cardiologist for the first time for consults. So this is another area which we are very actively looking at as to what is the effect of COVID over cardiac health in a span of time. And lastly, we do see in younger population a phenomenon that we observed over 18 months, that they were coming back to the emergency, possibly with infections, possibly with other comorbidities or other problems that they had. So this is something in evolution, and we'll give you more about this in coming years. Thank you, Dr. Sir.
Thank you, Dr. Joy. So we've seen the numbers, we've seen how data and the interplay between data and those numbers can provide useful insights for us to plan treatment and plan the way forward. And I think it's important now to turn our gaze to see what we can do about the numbers that we are seeing, whether it's in corporate India, rural India, and urban India. And I'd like to request Dr. Satya, who is the CEO of our preventive health portfolio, to talk about the role of proactive and preventive health in all these numbers that we have seen. Dr. Satya?
Thank you, Dr. Karan. So we've actually heard now the magnitude of the problem. We're all aware of this problem. Yet the numbers seem to grow year on year, and we hear more and more people succumbing to some of these lifestyle diseases that are actually easily preventable. What we will now share is how some of the studies that we are doing on the ground on shifting these lifestyle changes and actually making a difference in people's lives. Last time we shared the example of Total Health. This is a community development program in the Chittor district in Andhra Pradesh. And over 4 years, we have now been able to demonstrate sustained lifestyle management. A number of people were screened, and the diabetes and hypertension cohorts were actually followed over 4-5 years now. Specifically for medication adherence, the lifestyle changes itself to their diet, physical activity, and so on. And you see on the right here, about 500 plus diagnosed with diabetes, 85% continue to be managed and well under control. And a similar cohort of about 477 that were diagnosed with hypertension and adhered to the program over 4 years. We now have about 80% that have been managed in the hypertension cohort. In addition to this, we took inspiration, and at Apollo we have screened almost all of our hospital employees for these diseases through an annual health program. We've also extended this privilege to their spouses and adult children. And we've been able to stratify those that need follow-ups as well as programs such as this. And over the next year, we'll be working closely with them to help manage. In yet another cohort of Apollo employees, we actually looked deeper into the thin fat phenotype that we're all aware of in Asian Indians. Essentially, we genetically, as a population in India, have much more fat and far less lean muscle. This is how we are built. And as a result of that body composition, we actually need to take care of ourselves a little bit more and even think about our physical activity very differently. We took a pre-diabetic cohort and worked on their muscle strengthening as well as protein in their diet. So these were the only 2 changes, no medications whatsoever. But in a systematic way, monitored on a weekly basis, motivated to keep coming back on track and to shift the habits over a 12-week period. And as you can see here, on the left in the graph, those who were given one-time counseling, like we're all used to. A doctor tells us you need to do these things to actually shift your lifestyle. That's a one-time counseling. We actually, most of us tend to fall off track after initially perhaps trying to change our habits. On the right is actually the structured weekly monitoring and program that had follow-ups. And you see the difference over a 12-week period. Essentially, as more and more younger people are getting susceptible, we need to ensure that we get on the path to better wellness, but more importantly, that we stick to it. In another example with Apollo Clinics, the sugar program works with chronic diabetes patients. And with the long-term programs, they have dedicated coaches who call them consultations with doctors on a regular basis, pre-scheduled diagnostic tests, as well as now an app. Thanks to the pandemic, a lot of people were able to stay in touch with their coaches and the doctors using the app that is also backed by phone and video services. And as a result of it, be able to be monitored on a much more regular basis. Here are the mean glycosylated hemoglobin levels, a diabetic marker for patients that are visiting the sugar clinics. Those that were enrolled in the structured program, we saw a 1.2% reduction in glycosylated hemoglobin. Those that were not enrolled in any program, but simply came to visit in the sugar clinic and see the doctor on a regular basis, there was marginal reduction. Finally, last year we talked to you about ProHealth, which is a redefinition of the traditional health check. AI-based preventive health program that takes a personalized view of your risks based on your past family history, your medical history, as well as your lifestyle choices, and personalizes for you what tests are required. The diagnostic evaluation that happens with the doctor also gives you a sense for your current health status. But we go one step further. Through some of the AI work that Dr. Sujoy presented to you, we're able to now tell you if you continue to stay on the same path, not make any changes, where are you likely to go with your health? These predictive risk scores hopefully will nudge people to action. And once we are then able to share with you the path to wellness, we stay in touch through a set of nudges, through messages, through an app, as well as for those who need it with severe complications, a phone call from a health mentor on a regular basis. Over the last 6 to 12 months, we actually have seen a cohort of about 100,000 people who've gone through the ProHealth program, and about half have been touched in some way or the other. We've analyzed a subset of them for clinical outcomes, and as you can see, the glycosylated hemoglobin as a measure of diabetes has reduced, 0.7% reduction there. Weight, a key risk, 64% have lost weight on an average of almost 4 kilos. And blood pressure as well has been managed proactively through the program. And therefore, in summary, we're all aware of the silent epidemic, and this is increasingly impacting the young. 30 to 50-year-olds are finding themselves